Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Alex. How are you doing today?
Hey man, always a pleasure to spend some quality time hanging out with you and waxing poetic about terrifying medical encounters in far-flung areas of the world.
Yeah, I always enjoy it. And speaking of absolutely terrifying, we have a paper on burns and burn resuscitation. Man, this can get really complicated. But I think this was a really good paper.
Yeah, and I'm super excited too because it's hot off the press for anybody who's got all the free time in the world for keeping up on their podcasts. You know, the Skeptic's Guide to Emergency Medicine out of Canada. That dude, he's pretty funny, and he really likes to say these are all HOP articles, hot off the press. So this actually came out as an email blast just this month, even from the Eastern Association of Surgery for Trauma. They had a couple of articles that their reviewers thought were real hot, heavy-hitting articles. And this one in particular, Challenging Legacy Burn Resuscitation Paradigms with Fluid Restriction and Early Plasma, I think struck a chord for you and I. And so we figured we'd kind of tease this out a little bit more and see if and or how it applies to the special operations medic who could be encountering this in a prolonged field care environment. So it's always important to start with the doctrinal, why do I care about this? Or you might have to beat me, I can't remember what the rules are, but the why do I give a shit? And so when it comes to burns, there's a reason. Because unfortunately, our friends, teammates, partners, they get burns when we go into dangerous places and do dangerous things. And the recovery component of burn care is incredibly terrifying. If the carousel shows you this middle picture here, it's kind of hard to see what's actually in that dude's abdomen. But if you look really, really close, what you can see is that's actually an IV bag that's been cut open. It's one of the 3-liter bags. And they have sewn in that cut open IV bag to this dude's skin to keep his intestines from just flopping out onto the hospital bed because he's got so much edema. And you can also see the scrotal edema there from just profound swelling and over-resuscitation. And Dennis, I don't mean to speak for you, but I'm guessing you may be in a similar period of your life because, you know, when I was a young guy initially doing pre-hospital, far forward care, that sort of thing, and I'd been to a few schools and felt like I was pretty hot stuff and was told by instructors I could handle anything because of us. We were there to save lives, and you kind of go out thinking that you're ready for the world, and then you run into patients like these, oftentimes that don't have a good outcome, aren't able to get home to see their family. And I gotta tell you, it makes me a bit more queasy. These are really scary patients. They require really intensive care from very smart people who understand physiology and do this on a regular basis. I stole that middle picture from Dr. Cancio, who I think still is the burn trauma director at BAMC. Fun story, of course, the U.S. Army Institute of Surgical Research Burn Center at Fort Sam Houston in San Antonio was the very first burn center in the country. And it was stood up shortly after World War II because what was quickly realized is that going into the age of nuclear warfare, we're going to make and see a lot of burn injuries, which the civilian and military medicine community was unprepared for. And so, fun fact, burn care really came from the military, spread out to the civilian world, and we now tap into it pretty dramatically. That picture on the right with the leaky pipe, I was trying to find one of Dr. Cancio's old presentations that I really like, because he's got an introduction when you show up at the burn unit there for your rotations. And he tries to explain what burn fluid management is. But in a simple way, essentially consider the body as a leaky pipe. So you've got an intake to your pipe and you're putting those fluids in. Either maybe if their gut is working, you can absorb it with free water flushes through an NG tube or something. Probably it's going to be intravenous fluids are going into the pipe. And what is at the far end of the pipe that's coming out is your pee-pee. And in between, you've got a whole bunch of leaks. And that is all of those injured cells everywhere in the body, the skin, the insides, that are all leaking that intravascular fluid. And so that happens to be why the burn centers say that they care so much about how much is coming out at the end of that pipe. Right? That's why we always just foot stomp that urine output, is because if you're putting in just the right amount of fluid at the beginning of the pipe, or the IV fluids, you get just the right amount leaking, which is hopefully less and less as you heal their burn injury, then you should be able to know the right amount of fluid that's coming out at the end of the pipe. We pulled this one up because if you've been around for a while, you probably in the ICU heard the mantra that now we say it tongue-in-cheek because it's just ridiculous. But back in the day, I worked with a lot of intensivists 15, 20 years ago that would come down to the ER and say, critically ill patient, well, you got to swell to get well. And they would just fluid overload the shit out of these people. We're trying not to do that. So this article, I'm going to put you on the spot, Dennis. What do you know about the Glycocalyx that was brought up in this article?
So what do I know about it? It seems
after
to be
having done a quick Google search.
Yeah, it seems to be critically important. It has a giant name, and it's really a giant mystery, because other than my Wikipedia search, that's all I know. So.
Yeah, we were talking about this earlier before recording, but the Glycocalyx is this gooey bit of slime that actually lines your endothelium of your vasculature that tends to be a bioactive surface that we know almost nothing about, which is really terrifying. And if you want to learn a little bit more, I would strongly recommend the MCRIT Internet Book of Critical Care, which is MCRIT IBCC, that's got a whole page on Glycocalyx, which is pretty great. And also Life in the Fast Lane, which is an ER-specific podcast website that has a little bit, but it's very, it is written in ADHD format, like so many of our lovely ER doctors, is all I'll say about that. But the Glycocalyx is super important. You injure it, and then guess what happens to that lining? Just like if you ripped out the rubber lining inside a fire hose, well, that fire hose is just going to leak fluid all over. And that's the same thing that happens to our vasculature. Whereas if you've got a healthy Glycocalyx, considered a rubber lining inside there, then you don't get all that leaky capillary with all that interstitial fluid shift and third spacing, because you want to keep your nutrient-rich vascular fluid, your plasma and your RBCs, in the vasculature, circulating around, delivering nutrients and healing fluids, taking toxins, and going about its business. You don't want all of that stuff leaking out. And it was in the article about how quickly your abnormal saline left the vasculature. But do you have a rule that you use in general in the schoolhouse when you try and foot stomp that or teach it to guys?
Yes, 1/3, was it 1/3, 2/3 rule? So from what I understand, roughly 1/3 will remain in the vasculature in an hour of whatever volume you're given. But I think in practice, it's more like the 90 to 10% rule. Like the vast majority of that fluid in an hour is going to leave in the sick patient.
Yeah, 100%. And it's shocking for a lot of folks to appreciate that. I'd always heard it was there will be 1/3 of your liter left in the vasculature at 3 hours, the 3-3 rule. But I don't know, and it doesn't really matter. Everybody's different. This article actually says in the critically ill burn patient, it leaves the vasculature even faster. I think the take-home message, if you're not thinking about it, is even abnormal saline in a regular patient doesn't stay in the vasculature very long. It leaves and goes and gets third spaced. It, because of the osmotic pressure, goes in your cells. But we do know what stays in the vasculature. It's the stuff that's always been in there. It's plasma. And so this study, if we wanted to break it down into a PICO format, which again is often how we look at academic articles. So the population, the intervention, the comparator, and the outcome. For this study, the retrospective chart review that was done at a single academic burn center from 20 to 24 looked at these burn attending surgeons' preferred modality for treating burn patients. And I'm actually going to skip ahead to the comparator for a second and put you on the spot again. Sorry, dude. But so they compared their preferred modality for treating people to either the Parkland or what they called the modified Parkland. Do you happen to remember off the top of your head what the Parkland formula is? Because I will be very impressed.
All right. So 4 cc's per kilogram per TBSA. You calculate that out. That gives you a 24-hour volume. You take half of that volume and you give it in the first, let me think, the first 8 hours? No. Yeah, I think, yeah, the 1/3. Ooh, I'm fucking it up real quick. You get half of it in like the first 8 hours, the second half in the remaining 16 hours after that, and that gives you your 24-hour period. How close?
You are 100% right.
Oh,
yeah. Nailed it, bro. Apparently you got to hear something 7 times in your adult life to remember it forever. So it sounds like you have heard that at least 7 times.
Yeah.
But yeah, man, that was spot on. That was well done for all second and third degree burns over 10%. Yeah. So, and I know you guys foot stomp this at the JSOM-TC all the time. What is the single biggest problem with the Parkland?
So, I mean, it's just a lot of fluid. It's just a lot of fluid. And, you know, it's one of the early formulas that was used, which I guess is better than like what we normally do, which is like send it. But that's what led into Parkland, which then, of course, they bounce back and forth in their little gang fights, and essentially every formula on the planet lands between 2 mLs and 4 mLs per kilogram per TBSA.
Yeah. And so I think these guys, when they were working at a previous burn center, were using the Parkland and said, this is a terrible idea. It's way too much fluid. People early on, usually at outside smaller hospitals, tend to way overestimate the total burn surface area. And so they, because they overestimate the percent TBSA, you just flood these people. So it sounds like at a previous academic institution, they had decided to go from that 4 mgs per kg per TBSA down to 3. And then if people remained oliguric, you said for 2 hours, then they would get rescue plasma because, again, I mean, it makes sense. What is already in our vasculature? Plasma and RBCs. And that stuff tends to stay in there really well. They got a whole lot of blowback to that protocol because most of the previous studies look in all different disease processes have looked at colloids, which are similar to plasma, but they're just a much crappier version of it. And colloids in many studies have actually shown worse outcomes. And so we kind of got a bad taste in our mouth and said that anything with colloids is probably bad. And also, therefore, plasma is probably also bad, which is a little bit hard to stomach considering what's already in our vasculature. Plasma. And it does well every day of the year. I know. And I think in this study, what they had found is that 3 mgs per kg ended up doing better for patients overall by what outcome wasn't covered. And then they, couple of burn surgeons moved to a new trauma center and they basically got to be king of the roost. And they said, you know what? We're going 2 mgs per kg times ideal body weight TBSA, which I know you're going to get into, and early plasma. So we're just going to fire it as soon as they show up if they've got over 30% TBSA, either 1 unit or 2 units of plasma. And so that was, we'll say it's a study. It's a retrospective chart review. So we'll get into the pros and cons of that. And their outcome. Remember, there can only be one. I think that's Star Wars, I want to say. There's only one primary outcome. You can't have you can have a plural of a primary outcomes. And so in this one, it was the amount of fluids given during the first 24-hour injury period for second and third degree burns in those patients that were over 20% TBSA. They did a really nice job in the article listing the inclusion and exclusion criteria, and I'm going to encourage folks to just go pull up the article itself and look at it. Footstomp, if you go to scholar.google.com, you can just pull up the name of the article, which is Challenging Legacy Burn Resuscitation Paradigms with Fluid Restriction and Early Plasma. It's published in the Journal of American College of Surgeons in April of this year, and they've got the abstract freely available. So if you were trying to wrap your brain around this study, we're really trying to help you guys out so you can socialize this amongst yourselves. What would be that elevator pitch single slide deck of the study? It's that historically, we gave burn patients way too much fluid, just all the fluid. And you were talking about this earlier, I think, which is kind of the old mindset used to be, oh my God, this guy's sick. More cowbell?
Right. And I think so. Before I came in the military, I was in mechanical engineering, like this school. And so I learned lots of formulas. But one thing that in that environment you have is one formula to figure out one problem. And in medicine, it seems like we have like 12 formulas to figure out the same thing, which to me tells me like you don't actually know what the fuck you're talking about. So that's what burn formulas seem like to me. It's like 6+ people all fighting to get their name as like the one that rules them all, and none of them are true.
Yeah.
If that makes any sense. Like you can't, like nobody is cookie cutter. You can't say if I do this, everybody wins. Like that doesn't work. And I have yet to meet a burn attending that also thinks if I do this, everybody wins, because all of them go by urine output. So it's like, to me, like the whole formula thing, like it's okay. It's a good place to start. How about that?
Yeah. Well, and we're going to get into that with the rule of tens, because I think most people lose sight of that. But you're spot on. And let's be honest. I think medicine, just like special operations, is really your 80% solution. Because if you're using a multi-purpose tool, that means it does nothing really well. And I mean, I don't do anything well. I might do a few things, but thinking that we're all going to be subject matter experts in this. And if you're, an ER doctor alone and afraid in a critical access hospital, I don't know of any of them that see enough critically ill burn patients on a regular basis that this is a muscle memory for them, because they're dealing with so many other things, and they're really good at a lot of them. But you can't be good at everything. So this study was a retrospective chart review at a single center, which is going to start to tell you about some of the levels of evidence and the results. So the primary outcome was the amount of fluid given in the first 24-hour period for those patients who met the inclusion and exclusion criteria. And a foot stomp on that, if you want to go full nerd, it's really worth finding out if those inclusion and exclusion criteria for their retrospective study were determined ahead of time, or if they went through all of their data and said, oh, actually, I don't like this data, and then changed the inclusion and exclusion criteria to modify their data set after the fact, because that's real shady. And it happens all the time. So let's look at their primary outcome as the first line, and then some of their secondary outcomes, which are underpowered and What do you notice about that primary outcome between the intervention and the comparator groups?
Not a mathematician, but it seems like the 2 mLs per kilogram, they ultimately got less fluid than the people they gave 4 mLs per kilogram.
I am so glad you caught that, because it is kind of like the most basic thing in the world. Yeah, turns out if you give people less fluid, they receive less fluid, I think was the take-home message on that one.
Right. Mic drop.
Amazing. And we're done. Yeah. And just for the entire audience of 7 people listening, Dennis was the one who caught that. And, I am feeling very silly for not having seen that. But what's really, so yeah, I mean, you're 100% right. So their intervention group on the left there, the 2 mils per kg of ideal actual body weight. I can't remember what that
adjusted
is.
Body weight.
There you go. Yeah. With FFP, they ended up getting 1.7 mils per kg per TBSA. And then what's fascinating is the second line down below is urine output in mgs per kg per hour. And to put you on the spot yet again, what do you like to look for as a optimal urine output in a burn patient? What's that dribble at the end of the pipe?
What I'm looking for is 0.3 to 0.5 cc's per kilogram per hour.
Yeah.
You want to, since everybody in DOD weighs 100 kilograms, you're just looking for that 30 to 50. But if you want to do math, right? But that's generally what we're looking for. So that is a good 25% higher than what it probably should have been.
Yeah. I mean, that is just absolutely fascinating to me, to your point that the urine output on their minimal fluid treatment group was still way higher. And so then you look at their previous intervention, the 3 mils, and holy smokes, that is twice our goal, because our goal is 0.5 mils per kg. And then you look at the Parkland and you are at 300% urine output of where you should be. And so just to go back to the physiology, if you're pouring way too much fluid into the front of that pipe, it's just going to leak out all over the place, which is going to cause your trolley, your taco, and all of your downstream physiologic derangements within your tissue that's already in a critical ill state. So actually there may be room to go even lower. They can fully limbo this one. And all the other secondary outcomes, every single one, which were not powered adequately, showed tremendous improvement. The one on the bottom, everybody likes to talk about mortality. And so in their intervention group, they had a mortality of 3.5% compared to their historic norm of Parkland, which had a mortality benefit of, a mortality of 20%. So 1 in 5 of their patients used to die, and now it's 1 in 30-ish, essentially. 4% would be 5. Yeah. 1 in 5 versus 1 in 30. I know which of those 2 groups I would want a loved one to be in that are going to die. But there's a lot of confounders and is absolutely not powered accurately. So here in their article, they put in their recommended way of how they like to approach burn management. And they push this out to outside hospitals that are initially seeing a burn patient before sending them to their burn center. And when going through this, what did you notice?
One, the first thing because I'm reading it in order, I'm looking at the formula, and I'm like, wow, that is not easy at all. But then generally everything is pretty standard. I like that they delineate who's going to get 2 mLs versus 3 mLs. As far as like you have a confirmed inhalation injury, like they get 3 mLs. Just classically, those people need more fluid. The amount of 3rd degree burn, they're going to need more fluid. So I liked how they made that pretty easy. But kind of always goes back to rule number one. If you don't actually know what the frick you're doing, maybe you should call somebody. And that seems to be a recurring theme.
Yeah, absolutely. And you brought up the really good point that they really foot stomped on this article, that adjusted body weight index, which you dove into a little bit more than I. What did you end up taking out of that?
So the idea of, ideal body weight kind of goes by height, and it seems like a lot more things like ventilation, like different drugs are based off ideal body weight, and they're trying to eliminate essentially adipose tissue from the equation because it's not perfused. But they kind of noted like, hey, some of this, the difference between actual body weight and ideal body weight, some of that is actually muscle and is perfused. So this is kind of a happy medium. So they have adjusted body weight. So what you do, and I can't believe that I'm going to say it, but ideal body weight plus you take 0.4, multiply that by the difference between actual body weight minus their ideal body weight, and then you add that to your ideal body weight, and essentially they got a happy medium between what this guy actually weighs and what his ideal body weight is. They just, in a mathematical way, went in the middle, and we're going to adjust fluid based off of that. What I think is kind of funny, though, the formula that they sent out to everybody of 0.4 is not what they talked about in the article, which was 0.3, which I think that ratio, that constant is also probably pretty random to begin with. So that's why I'm saying I think they kind of winged it in a mathematical way, is somewhere in the middle.
Mm-hmm. Mm-hmm. Yeah, you're absolutely right. And just to foot stomp what you've been saying the whole time, what is it on step 6 there?
Yeah, well, I mean, everything, like titrate to urine output, like that is the most important thing that I've ever heard from any burn attending, is like adjust everything based off the urine output, which is, I'm willing to bet why even the 2 mLs per kilogram per TBSA group, why that was higher, is because I've heard this 1,000 times. The patient looks dry. Their heart rate is high. Their blood pressure is low. And usually, like everything about the patient, like if you're just looking at vital signs, it just screams like hypovolemic shock. And so, like, gut instinct says, give them some more fluid. It makes me feel better. It makes the numbers on the machine look better. And so I feel like I'm doing something. And so the patient, they get another unit. And then, another hour or whatever happens. And then somebody else does the same thing. And then that just repeats occasionally throughout the course of the stay. And now your patient is, 12, 18, 20, 30 liters positive. It's just how you end up with those pictures that you got.
You got to swell to get well, bro. This is one of those absolute Goldilocks disease processes where the answer to not overshooting fluid resuscitation is, I'm not telling you that the answer is to undershoot fluid resuscitation. That is an equally terrible way to treat these people, and will have equally terrible, if not worse, outcomes if you under-resuscitate them. These people 100% need to be resuscitated. You just got to hit that sweet spot, and you got to either be really comfortable doing it yourself or preferably phone a friend. So, in summary, I think given that this is a retrospective single center study, I would call it, from an academic journal perspective, probably level 3 evidence. What would you call it in our... Oh, have you got the doodad?
Yeah, I sure do.
Love that.
So,
what would you grade this one?
Was it 1, 2, 3, 4? Yeah, we're going from red as 1. I would say 4. Even though I poke fun at it, I like the paper. I think they looked at things that were important, obviously in a very convoluted and researchy way. But I think it's super important to give the right amount of fluid, and how do you define that in a really sick person is pretty complicated.
Mm-hmm. And this one, I think, isn't looking at how much, it's what fluid to give your patient. And you brought up the good point. Again, I think you've got all the good points on this one, that what they were comparing their intervention group is guys who got low dose normal saline, or LR, I guess. I think it was LR. And then immediately fired either 1 or 2 units of plasma if you were over 30% TBSA. And they compared that. Their 2 comparator groups were straight up Parkland with crystalloid fluids, the devil's juice, or that 3 mg per kg of devil's juice plus plasma only if oliguric, not making the PP. And so you brought up the fantastic point that they're not actually comparing apples to apples, because they said their whole lower crystalloid fluid was better. But what you brought up is their intervention is lower crystalloid fluid with plasma versus all the previous ones were crystalloid fluid. So the difference is plasma. And what I would argue, for a pro for this, is plasma seems to have a pretty good signal in burn treatments. It's actually been studied investigationally at the U.S. Army Institute for Surgical Research at their burn center, because it makes sense. Plasma is what's circulating in our body already, and it has that higher oncologic pressure. Consider the pressure head with all the little solutes that are floating around in there, your albumin, proteins. All of those tend to keep your junctions tight. And I think this 100%, this paper applies to the LISCO environment, applies to PFC, and hopefully we all have plasma. And, not to steal too many folks' thunder, but I have definitely heard Colonel Dr. Jen Gurney get very impassioned about what an even better resuscitation fluid might be in burn patients, because it's something that we already have inside our vasculature to begin with. And can you guess what that might be? Yes. And the next thing that they're looking at is actually whole blood. Because as you've mentioned before, these people get in a hypermetabolic state when their entire body is trying to heal itself. And so you get, you see all of these people are tachycardic, and they often get misdiagnosed as having sepsis, when in fact it's just a healing process. And that hypermetabolic state in these burn patients can actually get ahead of their ski tips. So they don't even have enough oxygen delivery capacity to all those healing tissue beds. But we have this beautiful fluid everywhere that not only has plasma, but also has oxygen carrying capacity, whole blood, which hopefully all of us have access to in a far forward environment. Certainly when we start to talk about being beyond the FLOT or working in UW, that may not be something you always have on hand. But I sure hope everybody in their PACE plan somewhere has the ability to procure supplies to perhaps do some life-saving Rolo or whatever the case may be. Looking at this article from an academic perspective, it does lose a few style points because it's not prospective, it's retrospective. It's not really randomized. It was essentially just one dude's experience. And it even says in the article that I thought my idea was better, so I just did it, which is, I think we've all run into Bob on the fob, who has a good idea, fairy whispering in his ear. In all foot stomp, to your point, it actually is a great idea, but it's a little bit of a squirrely way to approach an academic paper. You can tell the peer-reviewed editors at the Journal of the American College of Surgeons thought it was a good article, so they probably know what they're talking about, but it's not the best way to approach a academic journal article. And we talked about the Hawthorne effect a little bit before we recorded. I'm going to save everybody the benefit of me drolling on far too long. And if you're interested in the Hawthorne effect, you can just GTS, Google that stuff. This article came from a single center with some, I think, what would be pretty obvious provider bias in the article. Touched on a bunch of different ways. What else, kind of from a wrap up, can you think about for this article? Because it's pretty good.
I mean, I think it is pretty good. I mean, there are like gaping holes and flaws, and like if you had just spent like maybe a lunch hour thinking about how do I actually test this, not just get what I want, I think we could have set it up a bit better. Especially if you're thinking about, hey, I want to showcase, plasma's importance in this, not just I gave less fluid and it turns out like they got less. We could have set it up a bit better to highlight that. But like plasma, other colloids, there was nothing new about that in the burn resuscitation world. That we have, way back when you have your albumin, even into your head of starches and other things back in the day. Turns out that kills more people, so we stopped. But a colloid there's nothing new about it. So I guess I'm a little disappointed that they didn't just highlight that and like do the 2 ml per kilogram and then with or without plasma in whatever form, just to show is there a real difference or not.
Yeah, that's a pretty good point. And so I think this is one of the highest articles we've reviewed that you have rated from your prolonged field care level of, it's not level of evidence. What do we call that little grading scale?
Gestalt, I guess. I don't know,
okay.
Guess.
All right. So you're calling that in the blue zone there on that 5 pie chart, Dennis's PFC Gestalt chart. Yeah. So do you think that this is ready to be implemented in the field? Should guys start doing this?
No, not at all. I think it's something to definitely think about. I think it showed the efficacy of doing 2 mLs versus 4 mLs. So those lower volumes, like there was demonstrable benefit, even if it didn't have enough people to like prove it, I guess. At least showed like, hey, there's a trail out there. Maybe we could follow that in a safe way. Versus, hey, we're just going to keep doing whatever the frick we want. And so I think like there's probably value in going that direction. But I think ultimately it was a secondary outcome, like the urine outputs, like they weren't real dogged about the urine outputs. So that seems to me like they were pretty dogged about their formula, which is generally bad news. You always titrate to the urine output.
Dang, you are dropping some knowledge bombs today. That is so poignant. That's a great idea. Yeah. Super insightful. And then, just a foot stomp, if you are out there alone and afraid, you don't have to be, because there are some really great recommendations about what your practice guidelines can be. So the Joint Trauma System Clinical Practice Guideline, Burn Care, which was CPG number 12, if that kind of gives you an indication about how strongly they felt about this disease process, that this was just the very 12th. And I think we're up to 70 or 80 CPGs now. It's kind of fun to go through this author list. These are a whole bunch of old friends from when it first got published in 2007. It has been updated in September of 2023. As of yesterday, what is listed up there in the upper right column of contributors, Major Julie Rizzo, for those who have had the privilege of working for her, she just made Colonel yesterday. Send her a congratulations. She's pretty awesome. And as you know, a avid, voracious, she lives, breathes burn surgery and feels strongly about taking great care of her patients. you should absolutely spend some time working alongside her and all these other great folks. But like, if you want to trial by fire, maybe that's the wrong way of saying it. These guys know what they're doing. And at the end of that CPG that you can download as PDFs or print out or whatever the case may be, if you are outside the US, you have to use a VPN to get a US IP address, which is what some of our NATO colleagues taught me. You can pull this up on your phone. The worksheet is on page 13, I believe. And you were talking earlier about being able to phone a friend or call an adult into the room. And what is that on bullet point number 1 of this JTS burn resuscitation worksheet?
Looks like the advisor line or straight to the burn center.
Yeah, please call the burn center. And hopefully this will come up. Let's see if that's on my... Does that come through on the camera there? Can you see that? Okay. Yeah. So the worksheet has the DSN number to get to the U.S. Army Institute of Surgical Research Burn Center. You can also get a hold of them through the advisor line, or if you were dumb enough like me to steal one of their fridge magnets when you were going through there, they make their phone number super easy. So in San Antonio, it's area code 210, and then they've got their own one. So it's 210-222-BURN. That's their phone number. So that's 2876 is how you spell burn. Or email, which you can see listed there on the CPG. Because, at the end of the day, to get a little too real for a minute, we in this community are probably going to be taking care of one of our teammates, which I will just go ahead and say is one of our loved ones. And this is going to be a catastrophic injury. And you're probably going to be in a bad place, potentially without the ability to get to a good place anytime soon. And we all want our loved ones to get the best care they can. And so that means either being really good at this, having really good access to some great references, or having a really good comms pace plan in place to be able to phone a friend, an adult, or a burn surgeon. Because these injuries are really hard to manage well. And I think that these authors were passionate about it. And I will certainly be much more open to discussing the use of plasma in burn patients, because it looks like it's probably trending towards improving outcomes. And that is super important in this community.
I don't know if there was any final bits of advice you would give other than immediately call somebody. What would you think?
So we can't say it enough, which is these people immediately lose intravascular volume when their capillaries get leaky from the injury, and all of their interstitial fluid immediately goes into their cells and out of their vascular space. They then get hypotensive. They then go into multisystem organ failure. These people need a tremendous amount of volume up front so that they don't get centrally hypotensive. And then you immediately need to shift into what Dennis has been saying every single time, which is start turning up or down that spigot coming into these people by looking at their urine output. And again, on this JTS burn resuscitation worksheet, they've got the rules of 10, which I really like as a starting place. And then they will immediately say, adjust up or down I like to do 2 hours actually is when I make my adjustments, so I'm not chasing my tail. Start adjusting those fluid inputs based on your urine output as soon as practical. And guess what? Once your leaky capillaries have healed themselves, hopefully from plasma or whatever bioactive agent you've got available, then essentially your IV fluid input is going to equal the same as your urine output, because it's not going into the cells anymore, minus your incipient losses. And that in the burn unit is what they like to call closing the gap. So when that difference essentially delta goes down to 0, you have healed your burn patient. But I sure hope nobody has to deal with this, because it's pretty terrifying.
It is. Absolutely. Well, thank you, Alex. I really appreciate you going through this with me.
I think you found all the important bits on this one, man.
Well, I'm glad you at least were talking with me about it. How about that?
Sure, dude. Well, I don't think we've got any recommendations for diving into anything, but I'm always open to recommendations.
Okay. Awesome. Well, again, hey, thank you, Alex. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.